Let's now talk about the benign conditions of thyroid. And in this module, I talk about hypothyroidism, about goiter, about an isolated and a dominant thyroid nodule, and finally retrosternal goiter. So first we'll start with hyperthyroidism, and the first thing which you need to know are the features of hyperthyroidism. So the features of hyperthyroidism, you'll have a thin, irritable patient, and a classical symptom is heat intolerance, right? So if you're sitting in a cold room, this patient would still be feeling hot and would still be sweating. And these patients have a tremendous appetite, but they don't put on weight. And everyone is envious of them that, they can eat anything they want, but they don't put on any weight. So weight loss despite a good appetite. So these are the features. The patient is thin, irritable. There's weight loss despite a good appetite. So these patients can have tachycardia. They can have palpitations as well. There can be diarrhea and tremors. Fine tremors can also be seen in these patients. In fact, we get so many of medical students who message us, after getting a rank in their exam, that whether can we take up surgery or not. We have fine tremors in our hands. And I always tell them to find out the cause of the tremors. It is very easy for everyone to label them as essential tremors. But I always tell them to get a thyroid function test done. And there have been a couple of instances where the student has messaged me and told me that yes, that they had hyperthyroidism. And after treatment, their tremors went away and they eventually took up surgery. Right? So tremors can also be there in these patients. So these are the features of hyperthyroidism which are there. And like I told you, there can be heat intolerance. Whenever I talk about heat intolerance, I'm reminded of this picture of the desert of Dubai, where you have the desert safari, and you can see the car in which they take you does all kinds of stunts over these sand dunes. Now, one more thing which happens in hyperthyroidism is that patients can have oligomenorrhea. So everything is increasing, everything is becoming fast, but there can be oligomenorrhea. There can be menorrhagia as well, but oligomenorrhea is more common in patients with hyperthyroidism. So with these clinical features in mind, when the patient comes to us, we've already discussed that the first investigation which we will do are thyroid function tests. Now, when we carry out thyroid function tests in these patients, so the thyroid function tests, T3, T4 will usually be raised. And TSH will usually be reduced in patients with hyperthyroidism. Let's talk about the causes of hyperthyroidism to understand in which situations it can be otherwise as well. So the most common cause of hyperthyroidism is Graves' disease. Some people like to call it primary thyrotoxicosis as well. So that is the most common cause of hyperthyroidism, which we'll talk about in great detail. Solitary toxic nodule, toxic nodular goiter. These two things I showed you in a thyroid scan in the first module of thyroid. I showed you about thyroid scans, and I told you about a solitary toxic nodule and a toxic nodular goiter, which is also known as plumber's disease. And we will discuss later on in this module how to manage these two conditions as well. Factitious hyperthyroidism is when the patient is taking in more thyroxine from outside. And a very interesting incident was that I got an air hostess who was posted for a fibroadenoma surgery. And, she was very thin and she had these fine tremors. So the anesthetist asked for a thyroid function test. And when we did the thyroid function test, we were surprised because her TSH was very, very low. And when we asked her, she said that to maintain her weight and her figure, she keeps on taking thyroxine tablets. And she'd spoken to a medical friend of hers, and he had advised that, you can take these thyroxine tablets. And she had factitious hyperthyroidism. Jod-Bezos phenomena is iodine-induced hyperthyroidism. So when iodine is given, it can cause hypothyroidism, that is known as Wolff-Chaikoff phenomena, or it can cause hyperthyroidism, and that is known as Jod-Bezos phenomena. You can have a TSH secreting pituitary adenoma, and there will be raised TSH here. So this is the exception here. You will have a raised TSH. Unlike all other causes of hyperthyroidism, you'll have a raised TSH in these patients. Struma ovari. So struma ovari is another cause where there's ectopic thyroid tissue in the ovary. There is ectopic thyroid tissue in the ovary. And this is usually associated with cancer. And this ectopic thyroid tissue can secrete can secrete thyroxine and there can be hyperthyroidism. So one thing which I want you to remember in all these patients are the scan findings. So we do a thyroid scan in any patient who's hyperthyroid. We will do a thyroid scan. In Graves' disease, we know there will be diffuse increase uptake. There will be diffuse increase uptake in Graves' disease. Okay. In solitary toxic nodule, you will have a single hot nodule, which I'll show you later. In toxic nodular goiter, you'll have multiple nodules. Some would be hot, some would be cold. The two things that I want you to remember: factitious hyperthyroidism. Factitious hyperthyroidism, the thyroxine is coming from outside. So there will be decreased uptake in the thyroid gland in factitious hyperthyroidism. This is something which I want you to remember. Jod base dose, there will be increased uptake. In a TSH secreting pituitary adenoma, there will be diffuse increased uptake. And in struma ovari also, because the thyroxine is coming from the ovary, there will be decreased uptake in the thyroid gland, right? There'll be decrease in normal uptake in the thyroid gland. So these are the two exceptions, factitious and struma ovari, where the gland will not show increased uptake. In all the other conditions of hyperthyroidism, the gland will show increased uptake. So this is another thing which I want you to remember. Now, how do we manage hyperthyroidism? So there are three treatment methods to manage hyperthyroidism. The three treatment methods are drugs only. So only drugs can be used. We can use drugs followed by radioiodine ablation, and we can use drugs followed by surgery. So these are the three treatment options in patients with hyperthyroidism. About the drugs, you have already studied in pharmacology. Dr. Ranjan has taught you about propylthiouracil, PTU, and carbimazole. And carbimazole, these are the two agents which are used. So propylthiouracil, we know, inhibits the peripheral conversion of T4 to T3, and it inhibits the thyroid peroxidase enzyme, the TPO, thyroid peroxidase enzyme. Carbimazole only inhibits the thyroid peroxidase enzyme. We also know that thyroid peroxidase, and we also know that propylthiouracil is safer in pregnancy and lactation. Safer in pregnancy and lactation, and this question has been asked multiple times in the exam. And we also know that one side effect of both these agents, something which we need to monitor, is agranulocytosis. Which is why we need to monitor the complete blood count of patients who are on these medicines. So these are the medicines which are given in patients with hyperthyroidism. And irrespective of the treatment modality, we have to give medicines first, because before any intervention, we need to render the patient euthyroid. Okay, we need to make the patient euthyroid and then intervene. Otherwise, the patient is going to land up with a thyroid storm. So how do we prepare a patient? I will tell you that. But remember, we always use medicines first. Now, drugs followed by radioiodine ablation. We know iodine 131, we know it acts via beta rays and the half-life is 7 to 8 days. And it can be drugs followed by surgery. So these are the three treatment options which are common across all causes of hyperthyroidism. And we'll discuss the special conditions where each one of them is used. Now, like I just told you, if we have to do any intervention, we need to prepare a patient for surgery. And how do we prepare the patient for surgery? So 6 to 8 weeks before, we need to start the patient on antithyroid medications. That means propylthiouracil or carbimazole. And we also club them. We club them with long-acting beta blockers. Because in these patients, there is super sensitization of the sympathetic receptors. So it's not as if there's increased sympathetic drive. It's just that the receptors are super sensitized. So even with a small amount of catecholamines, the reaction is more. So we give long-acting beta blockers, and nadolol is preferred. Nadolol is preferred because it is an OD dose which can be used. And these antithyroid medications, the last dose of this antithyroid medication should be given on the evening before the surgery. So should be given evening before the surgery. We should continue the last dose of antithyroid medication. You should also know that these beta blockers should be continued for 7 days after surgery as well. 7 days after surgery as well. Why? Because the circulating hormone, which is already in circulation, has a half-life of 7 days. So even after an intervention, the patient can land up with thyroid storm, which is why these anti-thyroid medicines should be continued for 7 days. Now, 7 to 10 days before the surgery, these patients can also be given Lugol's iodine or potassium iodide. And the advantage of Lugol's iodine or potassium iodide is that it reduces the vascularity of the gland. It shrinks the gland or constipates the gland, and it makes surgery easier for us, right? So this is how we prepare a hyperthyroid patient for surgery. We first have to render them euthyroid. If we don't do this, then the patient can land up with a thyroid storm. Thyroid storm is uncontrolled thyrotoxicosis. Is thyroid storm. And in thyroid storm, what is going to happen? The clinical features which the patient is going to present with, the patient will come with dehydration. The patient is dehydrated. There are palpitations and arrhythmias. Palpitations which are due to arrhythmias, and arrhythmias are the leading cause of death in these patients. These patients can also have hypertensive crisis, so there can be hypertension also which can be there in these patients. And the most common cause of thyroid storm is an inadequately prepared patient. This question has also been asked in all possible exams. So if you don't prepare a patient properly before surgery, if you don't give antithyroid medications for an adequate duration, then a thyroid storm can occur. And what are the trigger factors for thyroid storms? So the most common trigger factor for thyroid storm is an upper respiratory tract viral infection. The other triggers can be trauma, or like I told you, surgery. These are the other triggers for thyroid storm. Even anesthetic agents can trigger a thyroid storm during surgery. So anesthetic agents can also trigger a thyroid storm. Now, I've already told you about the features of thyroid storms. How do we manage these patients? So management of thyroid storm, IV fluids have to be given. We have to manage hypothermia. These patients can have hypothermia as well. So we have to monitor the core temperature as well. IV steroids are given. IV corticosteroids are given. IV propranolol is a beta blocker which is given in these patients, and we will use propylthiouracil and carbimazole. Large doses of propylthiouracil and carbimazole are also used in patients with thyroid storm. So that was regarding thyroid storm and how we prepare a patient. This preparation of a patient is also asked in the viva. You're usually asked about thyroidectomy, or you might be shown the thyroidectomy specimen and you might be asked these questions. Now, with this information in mind, let's talk about the individual conditions which can give rise to hyperthyroidism. And the first condition which we need to discuss is Graves' disease. So Graves' disease, like I told you, is the most common cause of hyperthyroidism. It is the most common cause of hyperthyroidism. Some people also refer it to as primary thyrotoxicosis. Now, this is an autoimmune condition. And this autoimmune condition is more common in females as compared to males. And here there are autoantibodies against the thyroid receptors. Right, so thyroid receptor antibodies are there. And the old name for these thyroid receptor antibodies was LATs. LATs was long-acting thyroid stimulating antibodies. Long-acting thyroid stimulating antibodies. So the name itself suggests that these antibodies are going to stimulate the thyroid gland. They will stimulate the thyroid gland, and when they stimulate the thyroid gland, there'll be overproduction of thyroxine, and which is what is going to give rise to the hyperthyroid features. Now, Graves can be associated with pernicious anemia, with myasthenia gravis. So these are the associations where it can be associated with other autoimmune conditions as well. Now, what are the clinical features of a patient with Graves' disease? So the clinical features, if you look at the clinical features in a patient with Graves' disease, this patient is going to come with a diffuse goiter. Right, so there are no nodularities. There is a diffuse enlargement of the thyroid gland. There is a diffuse goiter which is present. These patients are going to have features of hyperthyroidism. So tremors will be one of the prominent features which will be there. So another characteristic feature in Graves' disease is the presence of eye signs. And I'm sure these eye signs would have been covered by Dr. Utsav in ophthalmology. I would also like to talk about them because they're frequently asked both in the theory and in your practical exam as well. And there are MCQs pertaining to it as well. Now, the eye signs which you can get are, of course, exophthalmos. So you can see a couple of patients. These were shared by a professor of endocrinology who's a senior of mine. So you can see exophthalmos here very clearly. That is bulging of the eyeballs. The other signs which can be there are Stellwag signs. So Stellwag sign is infrequent blinking. Which you get in these patients. And the other signs are Dalrymple sign. So Dalrymple sign is lid retraction. And what does that mean? So normally in all of us, we cannot see the upper sclera. The upper white portion is not visible. But when there's lid retraction, the upper sclera would be visible. Can you see in these patients the upper sclera? Can you see in this male the upper sclera is visible? So that is known as Dalrymple sign or lid retraction. You can also have von Graff's sign, and that is lid lag. And I've recorded a video where I've shown these eye signs that I'll show to you after these, where I've demonstrated how to elicit these eye signs. So lid lag is von Graff's sign. Now, both lid retraction and lid lag, why do they occur? They occur because of the spasm of the Muller's muscle. And the Muller's muscle is the autonomic component of levator palpebrae superioris. This is the autonomic component of LPS, that is levator palpebrae superioris. And because of the spasm of the Muller's muscle, you get these eye signs. Another eye sign which you can get is Geoffroy's sign. Geoffroy's sign is absence of forehead wrinkling. When the patient looks up. So why does this happen? So this happens because the eyeball is popping out, right? And because the eyeball is popping out, the field of upper vision is increased. So these patients don't need to frown when they look up. So that is Geoffroy's sign. And you can, of course, have Moebius sign. Moebius sign is a sign of severe toxicity, and this is loss of accommodation reflex. And I would now like you to see this video where I have demonstrated how to elicit these eye signs because they're very important from the final year point of view. One thing which I want to document and which I want you to know is regarding the eye signs. And they must have been covered in ophthalmology, but if you get a thyroid case in your college exams, you would be asked about eye signs as well, whether or not the patient has them or not. So of course, eye signs which are visible are exophthalmos. Lid retraction. What exactly do we mean by lid retraction? So normally you can see that the upper sclera is not visible. Lid retraction would mean that the upper sclera would become visible. That is lid retraction. Okay. There is also lid lag, which is von Graff's sign, and you're asked to elicit von Graff's sign in the college exams. First pointer, always you should be at the same eye level as the patient. If the patient is sitting and you are standing, and if I am the examiner, you've already failed the exam for me, right? So you should be at the same eye level as the patient.
That is the first thing when you're eliciting eye signs, right? Now, if I have to elicit von Graff's sign, I'm going to stand at a comfortable distance and I will ask the patient to follow the pen. Now, another common mistake which students make is that they don't support the head with the other hand. If you don't support the head with the other hand, the patient is going to move his head up and down and you will not be able to elicit the sign. Okay, so with one hand, support the head and the neck so that the patient doesn't move the head. And with the other hand, you take the pen and you ask the patient to follow the pen up and down, right? Don't move it too fast like this. You take the pen up and you bring it down. And when you bring it down, you will see that the eyeballs are coming down normally, but the upper lid is lagging behind. Okay? Stellwag sign is when you look at the patient and you see and you count how many times is the patient blinking in a minute and you compare it with the number of times you have blinked in a minute. So infrequent blinking is Stellwag sign. Geoffroy's sign is that normally when we look up, if all of us look up, we are going to frown. After a certain level, we will have wrinkles over the forehead. But in these patients, what has happened? The eyeballs are bulging out. So if the eyeballs are bulging out, they can easily look up without having wrinkles on the forehead. That is Geoffroy's sign. And finally, Moebius sign, which is a sign of severe toxicity, which is loss of accommodation reflex. Now, a very common mistake which students make here is what they will do is they'll ask the patient to focus on the pen and they'll bring the pen closer to the patient and they'll ask the patient to follow the pen and they'll look for convergence. This is the wrong method of doing Moebius sign. The correct method of doing Moebius sign is when you ask the patient to focus on a distant object. Patient focuses on a distant object and you introduce the pen suddenly in the line of sight and you ask the patient to shift his attention to the tip of the pen and then you look for convergence. Okay, that is the correct way of doing Moebius sign rather than bringing the pen close to the patient. So these are the points in thyroid examination which you should know for your college exams and even for your MCQ exams now.
Another feature which we can get in Graves' disease is pretibial myxedema. Now, pretibial myxedema is dermopathy which involves the lower limbs. Now, one point of confusion which I want to clarify, myxedema usually is seen in hypothyroidism, right? So a lot of students get confused and that is why this question was even asked in the FMG exam. They had shown an image and they had asked, in which condition is pretibial myxedema seen? Hypothyroidism or hyperthyroidism? So pretibial myxedema is a feature of hyperthyroidism. It is seen in Graves' disease. So there should be no confusion regarding this. Then these patients can also develop acropathy. What is acropathy? Acropathy is swelling of the digits. There can be dermopathy. And there is subperiosteal bone formation. There is subperiosteal bone formation which is there. Right? So these are the features of thyroid acropathy and these are the clinical features of Graves' disease which I wanted to highlight. Now, how do we make a diagnosis of Graves' disease? So the diagnosis of Graves' disease we can make by looking at the clinical features. We'll do clinical features. We will do a thyroid scan and in the thyroid scan in the first module I've already told you there'll be diffuse increased uptake. There is no nodularity in Graves' disease. And we can also see the autoantibody levels. I also want you to know that there are certain characteristic histopathological features of Graves' disease. So this is a classical slide of Graves' disease where you will see tall columnar cells. And because these cells are actively functioning, you can see scalloping of the colloid. So close to these cells, you will see scalloping or the colloid will be missing from there. So this is known as scalloping of colloid, which is very characteristic of Graves' disease. This has been asked in the exam as well. So we've discussed the clinical features, we've discussed the histopathological features. What about the management of Graves' disease? So we've already know that there are 3 treatment options to manage hyperthyroidism. We've discussed they can be drugs only, There can be drugs followed by radioiodine ablation, and it can be drugs followed by surgery. There can be drugs followed by surgery. So what are the various scenarios which you need to know, because these scenarios are frequently asked in the exam. So if you have Graves' disease in a child, then the child is managed with drugs only. That is how we manage a child. If you have a pregnant lady who has Graves' disease, this has been asked in the exam. If you have a pregnant lady, propylthiouracil is the drug which we will use. We've discussed because it is safer during pregnancy and lactation. If you have an adult patient without goiter who has not come with any swelling, as an adult patient without goiter, then in these patients the treatment option of choice would be drugs followed by radioiodine ablation. But if you have an adult with goiter, then it will be followed by drugs followed by surgery. I will discuss the surgical options with you in just a minute's time. What about an elderly patient who has comorbid conditions? Elderly patient with comorbid conditions. In an elderly patient with comorbid conditions, we will carry out drugs followed by radioiodine ablation. So drugs followed by radioiodine ablation. One exception to this rule which I want to tell you and which is very important. Now, one thing which you need to understand, that whenever we give radioiodine ablation in Graves' disease, it initially worsens the eye signs. There's worsening of the eye signs. Therefore, if you have a patient with eye signs, we will do drugs followed by surgery. Drugs followed by surgery will be done. Radioiodine ablation is avoided if there are major eye signs, because it can worsen the eye signs initially. So this you should know for your exam. This is very important. Now, what are the surgical options for Graves' disease? And there is a very good table which is given in Bailey, where it says that there are two surgical options for Graves' disease. We can either do subtotal thyroidectomy, or we can do total thyroidectomy. I've already told you what subtotal and total thyroidectomy entail. This we've discussed in the first module. Now, subtotal thyroidectomy versus total thyroidectomy. In total thyroidectomy, there is 100% thyroid failure. That means if you remove the entire gland, the patient will land up with hypothyroidism and you need to supplement it with thyroxine. In subtotal, what happens? In subtotal also, there is 100% failure over 30 years. So initially the patient might be euthyroid, right? Because some bit of gland is being left behind, but eventually the patient will become hypothyroid. So you will have to supplement thyroxine even after subtotal thyroidectomy. There is immediate relief from hyperthyroidism. In these patients. Here also there is immediate relief from hyperthyroidism. And in subtotal thyroidectomy, there is 5% recurrence rate which is there. The remnant tissue which we have left behind, there can be 5% recurrence rate. The other complications, if you remember the first module, I told you the risk of nerve injury, the risk of hypoparathyroidism is similar in both the situations. So if you look at everything in totality, total thyroidectomy is a better option. Why? Because if there is a recurrence, then it is very difficult to reoperate. It is very difficult to reoperate a previously dissected neck. It is very difficult to reoperate that. That is why these days surgeons are erring towards the side of total thyroidectomy in patients with Graves' disease. So I've told you the pros and cons of subtotal versus total thyroidectomy in patients with Graves. So that takes care of Graves' disease. Now there are two more conditions in hyperthyroidism which we need to talk about. The first one is Plummer's disease. Plummer's disease, you know, is toxic nodular goiter. So this is Plummer's disease. This is toxic nodular goiter or Plummer's disease. I had already shown you the scan in the first module. So this is toxic nodular goiter. Now, if you have a patient with toxic nodular goiter, females are more commonly affected than males with a ratio of 5:1. And you should also know that this is the second most common cause of hyperthyroidism. This is the second most common cause of hyperthyroidism in America. Most common is Graves' disease. This is the second most common cause of hyperthyroidism in America. This is a line directly out of Sebastian, which you should know about. Now, how do we manage Plummer's disease? We have the same three options which we've been discussing for hyperthyroidism. So, Plummer's disease, the management is we will give drugs for a short duration of time to make the patient euthyroid. And this will be followed by surgery. And the surgery which is usually done when there is toxic nodular goiter is total thyroidectomy. So we will carry out total thyroidectomy and then we will do thyroxine replacement in these patients. Okay. So this is the treatment for Plummer's disease. So another thing which you should remember that potassium iodide should be avoided in patients with toxic nodular goiter. Now, we discussed that potassium iodide basically helps in reducing the vascularity of the gland and it shrinks the gland before the surgery. But the problem in Plummer's disease is that if you give potassium iodide, if potassium iodide is given, it can give rise to Jod base dose phenomena. It can give rise to Jod base dose phenomena, which we've discussed as iodine-induced hyperthyroidism. So it can be counterproductive in patients with toxic nodular goiter. That is what is written in Sebastian, latest Sebastian as well, that we should avoid it in toxic nodular goiter. Now, what about a solitary toxic nodule? So a solitary toxic nodule, we have seen here, this is a solitary toxic nodule where this single nodule is hyperfunctioning. Okay. Now, solitary toxic nodule is also seen in the 5th decade of life. This is usually seen in the 5th decade of life, and females are again more commonly affected than males. And the management of patients with solitary toxic nodule. So the management in these patients is again drugs followed by radioiodine ablation. Now, why is radioiodine ablation preferred in a solitary toxic nodule? Because this nodule is going to take up majority of the iodine. So when you give radioiodine, majority of the iodine will get concentrated in this nodule only and it will destroy this nodule. The rest of the gland would remain normal. So that is why radioiodine ablation is preferred, although some people like to do a hemithyroidectomy as well. But if you have to mark one option, you will go with radioiodine ablation. You should also know that solitary toxic nodules are associated with G-coupled protein. G-coupled shock protein can be associated with solitary toxic nodule. So this takes care of all the causes of hyperthyroidism, where I've discussed the clinical features, the management, and the individual conditions as well. We now move on to hypothyroidism. And in hypothyroidism, the clinical features are opposite of that of hyperthyroidism. So you have a dull, lethargic patient who is obese, who even if he doesn't eat much, he puts on weight. There is alopecia, bradycardia, constipation, weight gain, and there is cold intolerance as opposed to heat intolerance in hyper. There is cold intolerance here, and this is a picture of the northeast part of our country. We had gone there for a visit, a beautiful, lake which was there. So in Sikkim, so excellent site, a nice cold area. But patients with hypothyroidism, I was being accompanied by two patients who were hypothyroid, and they were feeling excessively cold here, right? They were feeling excessively cold. So that is what happens. There is cold intolerance in hypothyroidism. Now, in hypothyroidism, there can be menorrhagia. So as opposed to hyperthyroidism where there was oligomenorrhea, there can be menorrhagia in patients with hypothyroidism. Now, like there was thyroid storm in hyperthyroidism, you can have a myxedema attack. So a myxedema attack would be the patient would have bradycardia. The patient can have bradycardia. The patient can have altered sensorium. Right? There can be constipation, bradycardia, altered sensorium. So these myxedemic attacks are also predisposed by viral infections. Like thyroid storm was being predisposed by viral infection, these myxedemic attacks can also get predisposed by viral infections. So these are the clinical features. Now, when we get a patient with hypothyroidism and when we do the thyroid function test, usually T3, T4 will be reduced. Usually T3, T4 will be reduced and TSH is going to be raised in these patients. That's the usual norm. There are a few exceptions which I will tell you about. Now, the causes of hypothyroidism, the most common cause overall, and this is written in Bailey, Sebastian, Harrison, everywhere, the most common overall is iodine deficiency, is still iodine deficiency. The most common in the Western world is Hashimoto's thyroiditis, which is also known as lymphocytic thyroiditis. This we'll talk about in detail in some time. You can have Wolff-Chaikoff phenomena. So Wolff-Chaikoff is the opposite of Jode-Bezos. Jode-Bezos was iodine-induced hyperthyroidism, whereas Wolff-Chaikoff phenomena is iodine-induced hypothyroidism. So this is iodine-induced hypothyroidism is Wolff-Chaikoff phenomena. You can have a non-functioning pituitary adenoma. So if a pituitary adenoma occupies space but it is not releasing TSH, then there can be hypothyroidism as well. You can have Sheehan syndrome. This Dr. Sakshi has covered in great detail. This is postpartum apoplexy, postpartum pituitary apoplexy or bleeding in the pituitary gland, and this can give rise to a global decline in pituitary function. So because of this global decline in pituitary function, TSH release is also hampered and that can give rise to hypothyroidism. Then there can be dyshormone genesis, and dyshormone genesis is because of defects in the thyroid peroxidase enzyme. You can have euthyroid 6 syndrome. So euthyroid 6 syndrome is when in patients with chronic non-thyroidal illness, so there is chronic non-thyroidal illness and that can give rise to decreased thyroid hormone. That is known as euthyroid 6 syndrome. Okay. Refetoff syndrome is seen in elderly patients. Refetoff syndrome can be seen in elderly patients and this is end organ resistance to T4. This is end organ resistance to T4. So these are the various causes of hypothyroidism. Now, a word of caution here. Look, these causes of hypo and hyperthyroidism are asked frequently in the Viva as well for final year students. And often it is a tendency when we are sitting in Vivas, we are very nervous. And what we say are the least common causes first. So you should never make that mistake. I mean, so many times I've taken Vivas and the student will say Refetoff syndrome, euthyroid 6 syndrome, Sheehan syndrome. So all the rare causes will come out first. But in a Viva, the trick always is to talk about common causes first. Okay, so make sure whenever you're asked to enumerate causes of any condition, you should talk about the common causes first. Now, with this information, we need to talk about the thyroiditis, the various types of thyroiditis, because invariably there is one MCQ in all exams regarding thyroiditis. So the first type of thyroiditis which we need to talk about is Hashimoto's thyroiditis. Hashimoto's thyroiditis is also known as lymphocytic thyroiditis. And this is the most common thyroiditis which is present. So this is the most common thyroiditis and it is the most common cause of hypothyroidism in Western world as well. Females are affected more than males. And it is an autoimmune condition. So it is an autoimmune condition which is associated with HLA-DR3 and B8. This can be associated with Downs and Turner syndrome and there is a very strong hereditary component. There is a 9 times risk of Hashimoto's in a first degree relative. So 9 times risk of Hashimoto's is there. If somebody has Hashimoto's, then in the family subsequent generation, 9 times risk of Hashimoto's getting passed on is there. So there's a strong hereditary component to Hashimoto's thyroiditis as well. Now in Hashimoto's thyroiditis, there are autoantibodies which are formed. And these autoantibodies are against the thyroid receptor. So as opposed to the stimulating antibodies which we were seeing in hyperthyroidism, these are blocking antibodies. Okay, these are blocking antibodies which are there. Then there can be autoantibodies against TPO, against thyroid peroxidase enzyme, and there can be autoantibodies against thyroglobin. And I've already told you the significance of having antibodies against thyroglobin when we were talking about thyroid cancers. I told you in differentiated thyroid cancers, thyroglobin was a tumor marker. And if there were antibodies against thyroglobin, then we could not rely on thyroglobin as a tumor marker, right? So these are the autoantibodies which are present in patients with Hashimoto's thyroiditis. Now, what is the clinical course of events in Hashimoto's thyroiditis? So in Hashimoto's thyroiditis, what happens is that initially these autoantibodies are formed. These autoantibodies are formed, and these autoantibodies are going to stimulate, lymphocytes to infiltrate the gland. So stimulate lymphocytes to infiltrate the gland. Now, when these lymphocytes infiltrate the gland, what are they going to do? They are going to destroy the follicles. They will destroy the follicles. And when they destroy the follicles, what will happen initially? Stored thyroid hormone will be released into circulation. Stored thyroid hormone will be released in the circulation. So when the stored thyroid hormone is released in the circulation, that is going to give rise to a phase of hyperthyroidism. And this is also known as Hashimotoxicosis. So there'll be a brief phase of hyperthyroidism, which is known as the phase of Hashimotoxicosis. Now, once the follicles have been destroyed, follicles cannot regenerate. Because of repeated attacks. Follicles cannot regenerate. Okay, there's repeated attacks from lymphocytes, so the follicles won't be able to regenerate, and this is going to give rise to prolonged hypothyroidism. So that is the clinical course of events in Hashimoto's thyroiditis. Now, if I have to draw a graph and depict this to you, so what is going to happen that initially there will be a brief phase of hyperthyroidism, which I explained to you because of destruction of the follicles, and there will be a prolonged phase of hypothyroidism. So that is the course of events in Hashimoto's thyroiditis. Now, what are the other clinical features which we are going to see? So the clinical features which you will see is that the patient can come with a diffuse goiter. Diffuse enlargement of the gland. There will be features of hypothyroidism which will be present as well. So features of hypothyroidism will also be present. Now, how do we confirm the diagnosis? So the diagnosis of Hashimoto's thyroiditis is confirmed by the presence of autoantibody levels. So clinical features would lead us to autoantibody levels, and that's how we confirm the diagnosis of Hashimoto's thyroiditis. If you do an ultrasound in these patients, you can get a pseudonodular appearance. So you might get an appearance as if the patient has multinodular goiter, but in reality, it is just a pseudonodular appearance which you get on ultrasound. Now, if you do histopathology in these patients, the histopathology, you will see lymphocytic infiltration. So you will see lymphocytic infiltration within the thyroid gland is what you will see in Hashimoto's thyroiditis. Also in Hashimoto's thyroiditis, you can even see the presence of Hürthle cells. We've already discussed that Hürthle cells can be present at many places like Hashimoto's thyroiditis, follicular carcinoma thyroid, Hürthle cell adenoma, Hürthle cell carcinoma, and thyroid lymphoma. So these are the places where Hürthle cells can be seen in thyroid. One of them is Hashimoto's thyroiditis as well. Now, long-standing Hashimoto's thyroiditis can predispose the patient to certain cancers also. So long-standing Hashimoto's thyroiditis, there can be increased risk of lymphoma, thyroid lymphoma, which is the most common, right? So this you should know. Most commonly, there can be increased risk of lymphoma. There can be increased risk of PTC and follicular thyroid cancer as well. But commonly, it is thyroid lymphoma, which can occur in long-standing Hashimoto's patients. So the management of Hashimoto's thyroiditis, we have to manage the hypothyroidism. So hypothyroidism we manage by thyroxine replacement. We manage by thyroxine replacement. Now, this must have been covered by Dr. Rakesh in great detail as well, that when we have to manage hypothyroidism, we gradually start with a lower dose and we gradually keep on titrating the dose upwards. That's the routine trend where we go from lower dose and we titrate it upwards. And that was a question which was asked in one of the exams, in the UPSC exam and in the FMG exam, where they had asked that how is the dosage done for a patient with hypothyroidism. So usually the options were that it is usually started at 25 micrograms and we gradually titrate it up by monitoring the TSH levels. So that was the correct answer there. Now in hypothyroidism, if goiter is there, if goiter is present, then we need to carry out surgery. And the surgery which can be done is either subtotal, near total or total thyroidectomy depending on the extent of the condition. So that is the surgery which is done if a goiter is present in Hashimoto's thyroiditis. Another cause of thyroiditis is postpartum thyroiditis. Now, postpartum thyroiditis is a type of subacute thyroiditis, and this is the second most common thyroiditis which is present. So this you should know, very important. These are direct lines from the latest Sebastian. It is the second most common autoimmune thyroiditis which is there after Hashimoto's thyroiditis. 10% of women who become pregnant suffer from postpartum thyroiditis, and it usually manifests between 2 to 12 months postpartum. It is similar to Hashimoto's in many regards. It is similar because there is a short thyrotoxic phase, which I've already explained to you, that initially, because of destruction of follicles, there'll be a phase of thyrotoxicosis. There is presence of anti-TPO antibodies, anti-thyroid peroxidase antibodies, and there is a tenfold risk of Hashimoto's ultimately in these patients. So, tenfold increase in Hashimoto's thyroiditis in those patients who suffer from postpartum thyroiditis. Okay, so this you should know about. This is postpartum. Usually it has a self-limiting course, and when there is hypothyroidism, you just need to replace thyroxine in these patients. One more thing is that this can be differentiated from D. quervans, which will be the next condition which I'll talk about. D. quervans thyroiditis versus postpartum thyroiditis. In D. quervans, there is increased ESR and HLA-B35 is implicated. Whereas in patients with postpartum, ESR is not raised and HLA-B35 is not implicated. So these are the points of differences between postpartum and D. quervans thyroiditis. Now, D. quervans or viral or granulomatous thyroiditis, this is also a type of subacute thyroiditis. Okay, this is also a type of subacute thyroiditis which is associated with HLA-B35. Now, in this condition of D. quervans or viral thyroiditis, the sentinel event, the starting or the triggering event is a viral upper respiratory tract infection, is a viral URTI. So after this viral URTI, 4 to 6 weeks later, what is going to happen? That lymphocytes will infiltrate the gland. So lymphocytes infiltrate the gland. And when lymphocytes infiltrate the gland, they will again destroy the follicles. And when they destroy the follicles, there will be a brief phase of hyperthyroidism. So there will be a brief phase of increase hyperthyroidism will be there briefly because of stored hormone being released. Then this will be followed by hypothyroidism because the follicles have been destroyed. This will be followed by hypothyroidism. But the main difference between D. quervans and Hashimoto's is that in this condition, follicles will gradually regenerate. So follicles gradually regenerate in this condition. So follicles are gradually going to regenerate in this condition, and therefore if I have to draw a graph of D. quervans thyroiditis, what is going to happen here is that initially there will be hyperthyroidism, then hypothyroidism, but in 3 to 4 months time, the patient will come back to euthyroid status. So this condition is a self-limiting condition. It is a self-limiting condition whereas in 3 to 4 months, the patient again comes back to euthyroid status. Now, one very important thing in D-Curvans thyroiditis is that after this URTI, when these lymphocytes infiltrate the gland, there is going to be painful neck enlargement. So these patients usually complain of pain in the neck. There is a swelling, and these patients can also have malaise and low-grade fever. But pain is a very prominent feature which you need to remember, which is seen in D-Curvans thyroiditis, and it is not seen in Riedel's thyroiditis, which I'm going to talk about next. So that's how we can differentiate the two conditions. But pain is a prominent feature here. So the management of viral or D-Curvans thyroiditis is symptomatic treatment, where we just have to give thyroxine in the hypothyroid phase. And I've already told you how to differentiate this condition from postpartum thyroiditis. In postpartum thyroiditis, ESR will not be raised. Here, ESR is raised, and it is associated with HLA B35 as well. The final type of thyroiditis which we need to discuss is Riedel's thyroiditis. Now, Riedel's thyroiditis is also known as fibrosing thyroiditis. So, Riedel's thyroiditis is also known as fibrosing thyroiditis. Now, this fibrosing thyroiditis is associated with IgG4. Now, wherever we've discussed IgG4, it has been associated with fibrosis. Like we've discussed retroperitoneal fibrosis in urology. We've discussed fibrosing pancreatitis in benign pancreas module. They all have been associated with IgG4. Now, this condition can also be associated with conditions like Peyronie's disease. Peyronie's disease I've covered in penile module, where there is deposition of calcific plaques in the corpora. And they can also be associated with Dupuytren's contracture. So, this condition can be associated with other conditions as well. Now, in Riedel's thyroiditis, what happens? That there is fibrosis within the gland and in the vicinity of the gland. Fibrosis within the gland and in the vicinity of the gland. So, when there is fibrosis within the gland, you get a very hard, woody thyroid. We get a very hard, woody thyroid when there's fibrosis within the gland, right? And a very hard, woody thyroid, a differential diagnosis for this condition is anaplastic cancer, and which is why I told you that to differentiate this two, we need to do a true cut biopsy to confirm the diagnosis and to differentiate the two conditions. Okay, so true cut biopsy, if you remember, I told you 3 indications: anaplastic cancer, Riedel's thyroiditis, thyroid lymphoma. Okay. One more thing which you need to remember, that here there is painless neck enlargement, and that is the point which helps us in differentiating this condition. From granulomatous or viral or D-Curvans thyroiditis, where there is a painful neck enlargement. Now, if there is fibrosis in the vicinity of the gland, then the recurrent laryngeal nerve can become involved, and that can give rise to hoarseness. Of voice. Or the trachea can become involved, and there can be stridor or dyspnea. In these patients. And rarely the esophagus can also become involved, and there can be dysphagia also in these patients. Now, the management of Riedel's thyroiditis, the management of these patients is steroids and tamoxifen. Tamoxifen is selective estrogen receptor modulator, which we've read about in breast cancer. That also has a role in patients with Riedel's thyroiditis. If pressure symptoms are there, present, then we can do surgery. Then we can carry out surgery. And the most commonly done surgery is an isthmusectomy. And this isthmusectomy is done to relieve the pressure over the trachea. So that was the management of Riedel's thyroiditis, and that takes care of all the thyroiditis, which I've told you are very important from the point of view of the exam. So with this, we come to the end of hypothyroidism and hyperthyroidism. Now there are certain other benign conditions in thyroid which we need to discuss. So let's talk about goiter now. Goiter is a thyroid swelling. The literal definition of goiter is a thyroid swelling. Now goiters can either be diffuse goiters or they can be multinodular goiters. So how do these goiters start off? So whenever there's a phase of increased demand is there, like you have puberty and pregnancy, and if the patient during these phases is living in an iodine deficient area, then because of increased TSH, there will be a diffuse goiter which will form. Okay, so because of TSH, there will be a diffuse goiter which is going to form whenever there is a phase of increased demand. Now, once a diffuse goiter forms, then because of variable stimulation, in a diffuse goiter, there is variable stimulation by TSH. There is variable stimulation by TSH in the long run. So because of variable stimulation by TSH over a period of time, there will be some nodules which will be in advanced stage, some nodules which will just start forming. And because of this, the patient can develop a multinodular goiter. Okay, so you can see here it starts off with a diffuse goiter, and in iodine deficient areas, ultimately because of variable stimulation, the patient can land up with a multinodular goiter. Now, in a multinodular goiter, the active area is the internodular area. Of course, multinodular goiters, these patients can develop hot and cold nodules as well in the long run. Now, there are certain definitions which I want you to know, and these definitions are frequently asked in the Viva. So, the first definition is a multinodular goiter. Multinodular goiter means when there are multiple nodules. When there are multiple nodules in the gland, it is a multinodular goiter. You can have an isolated thyroid nodule. There can be an isolated thyroid nodule. And isolated thyroid nodule is when only one nodule is felt, only one nodule is palpable, but the rest of the gland is not palpable. Rest of the gland is not palpable. That is known as isolated thyroid nodule. And the third one is a dominant thyroid nodule. Dominant thyroid nodule is when nodule is palpable, one nodule is palpable, but the rest of the gland is also palpable. That becomes a dominant thyroid nodule. So these are the three definitions which I want you to know about. Now, another thing which we need to know is the risk of malignancy in a thyroid nodule. And this is extremely important, especially for your INI CET exam and your SS exams. And this is a table directly from Bailey, which tells us the risk in an isolated and dominant thyroid nodule. Now, in an isolated thyroid nodule, the overall risk, if it is a solid nodule, is 24%, whereas if it's a cystic nodule, it is 12%. Now, the risk is always more in males and it is 1/4 in females. So, in males, it is 48%, in females, it is 12%. If it's a cystic one, in males, it is 24%, and in females, it is 6%. Dominant thyroid nodule, if it is a solid nodule, the risk is 12%. If it's a cystic nodule, it is 6%. In males, it is 24%, and females, it is 6%. If it's a cystic nodule, in males, it is 12%, and females, it is 3%. The overall risk in a generalized thyroid swelling is just 3%. Now, one more thing which I want you to know here is if you are presented with a patient with a thyroid nodule, how do we work this patient up? This comes as a long question in your university exams, and a lot of MCQs can also be answered if you understand this concept. And this is basically a gist of the entire thyroid chapter which we've discussed over the 3 modules. So if you get a patient with a thyroid nodule, we know that the first investigation which we are going to do are thyroid function tests. So when we do the thyroid function tests in these patients, we can get two types of pictures. We can get a patient with low TSH. We can get low TSH and hyperthyroid features. Or we can get a normal TSH or raised TSH, okay, which is your hypothyroid picture. Now, if it is low TSH and hyperthyroid kind of picture, we know that these patients will first go in for a thyroid scan. We have to carry out a thyroid scan in these patients, and we've discussed the various conditions and what do they look like on thyroid scan. Now, if it is normal TSH or raised TSH, these patients are going to undergo an ultrasound. And on the ultrasound, they will be labeled on the basis of the TIRADS score, right? On the basis of the TIRADS score. If you remember, TIRADS I had covered in module 1. TIRADS is Thyroid Imaging Reporting and Data Systems. And based on that, we will determine whether the patient requires an FNAC or does not require an FNAC, right? So based on this, we will determine whether the patient, we have to carry out an FNAC or we don't have to carry out an FNAC. And if we do an FNAC, it is usually an USG guided FNAC which we carry out. And when we do this USG guided FNAC, we will label it according to the Thai-1 to Thai-5 classification, which I told you is the Bethesda classification, right? Which is the Bethesda or the Royal College of Pathologists classification. So based on this Thai-1 to Thai-5, we will manage the nodule accordingly. So this is how we work up a patient with thyroid nodule, and then we come to the diagnosis and we manage it accordingly. The final thing in thyroid nodules, but a very important topic because a lot of questions have been asked from this, is retrosternal goiter. So retrosternal goiter basically means when the thyroid swelling goes behind the sternum into the mediastinum, right? So it goes behind the sternum into the mediastinum. That is a retrosternal goiter. Now, retrosternal goiters can be of two types. You can either have a primary retrosternal goiter or you can have a secondary retrosternal goiter. Primary retrosternal goiters are just 10%, and this occurs when there's ectopic tissue in the mediastinum. When there is ectopic thyroid tissue in the mediastinum and it starts to grow there, that gives rise to a primary retrosternal goiter. This is also known as a primary mediastinal goiter. This is also known as a primary mediastinal goiter, and the blood vessels are the mediastinal vessels. So it derives its blood supply from the mediastinal vessels only. Secondary retrosternal goiter is also known as plunging goiter. Another name for this is plunging goiter. So plunging goiter basically means that it starts in the neck. It starts in the neck and then it goes behind the retrosternum. Then it goes behind the sternum. So then there's retrosternal extension. Then there is retrosternal extension, and this is 90% of all retrosternal goiters. Now, secondary retrosternal goiters, the blood supply of secondary retrosternal goiters is from the neck vessels. So they derive that blood supply from the neck vessels. And the advantage is if I can control the neck vessels, then I can easily remove this thyroid swelling. So these are the two types of retrosternal goiters which are there, and the clinical features with which the patient will present, whether it is primary or secondary, the patient is going to come with a swelling. And the key thing here is that the lower limit of the swelling cannot be felt. Lower limit cannot be felt. Lower limit of the swelling cannot be felt on examination, which is why if you see the thyroid case which I have discussed, I have told you that a very important thing which you have to say is whether we are able to feel the lower limit of the swelling or not. Then these patients can have dyspnea because there can be pressure over the trachea, so there can be dyspnea. There can be stridor as well. And on examination, you can see that the trachea is even shifted to one side. Right? So dyspnea, stridor can also happen in these patients. And there is one clinical sign which you can see that is known as Pemberton sign. Pemberton sign is when you ask these patients to lift their hands above their head. That is Pemberton sign. And because of pressure over the thoracic outlet, these patients will have facial congestion or conjunctival congestion. So you can see this patient when he's lifting his hands, then there is facial congestion which is developing. So that is Pemberton sign, which can be seen in retrosternal goiters as well. Now, if you do imaging for retrosternal goiters, you can see here that this is the retrosternal goiter, the mass which you can see, and you can see that the trachea has also been shifted to one side. So this is what we are seeing on an X-ray. But the imaging investigation of choice in patients with retrosternal goiters is a CECT neck and thorax, which will tell us about the extent of the swelling, and it will tell us the relationships with the vital structures and the blood vessels as well. Now, the management, of course, for these patients is surgery. The management is surgery. And a very important question which has been asked, that majority of the retrosternal goiters, how will we remove them? Which surgical approach will we follow? So majority can be removed via the cervical or the neck incision. Majority can be removed via the cervical or the neck incision. Why? Because 90% are secondary retrosternal goiters. That means they are starting in the neck and then they are going behind the sternum. So majority can be removed via the cervical or the neck incision. This question has been asked at least 10 times in various exams. Now, of course, there will be certain indications where we need to carry out a median sternotomy, where we need to cut open the sternum to get proper access. So what are the indications for median sternotomy in retrosternal goiters? This has also been asked. So if you have a primary mediastinal goiter, if you have a large malignant retrosternal goiter, or if there is a recurrence in the mediastinum. These are the indications when we need to carry out a median sternotomy. Otherwise, majority can be removed via a neck or a cervical incision. So that brings us to the end of the thyroid module. And from this module, the short notes which you need to prepare for your college exams are Graves' disease, Hashimoto's thyroiditis, D. quervans thyroiditis, retrosternal goiters. So one of these 4 short notes are definitely asked in your college exams. And I've told you can also be asked a long question regarding the approach to a thyroid nodule and what are the investigations which are done. So in that, you will have to talk about thyroid function tests, you'll have to talk about ultrasound, about thyroids, about thyroid FNAC, and the basic schema which I've just explained to you of how do we approach a thyroid nodule. Before we end this module, let's quickly do some MCQs. You have a 45-year-old lady with painless neck swelling who presented with palpitations and weight loss. So palpitations, weight loss, our mind is already going towards the direction of hyperthyroidism. Thyroid function test revealed increased T3, T4 and low TSH and negative TSH antibodies. Iodine scan showed multiple thyroid nodules with increased uptake. So multiple nodules which are increased uptake. So this is toxic nodular goiter. We are dealing with toxic nodular goiter. Initial antithyroid treatment was given. What is the next step? So next step in these patients is going to be near total thyroidectomy or a total thyroidectomy. Okay. Because toxic nodular goiter, we have to carry out surgery. Which of the following statements is true about retrosternal goiters? Operated in all patients regardless of symptoms. Sternal incision is always required to operate. This is false. It receives blood supply from thoracodorsal artery, and most of the retrosternal goiters can be removed by the neck incision. This is a true statement. This we've just discussed. Which of the following is the most common cause of thyroid storm in thyroidectomy? This I've told you is inadequate patient preparation. Please remember, it is not rough handling during thyroid surgery. Rough handling can also give rise to thyroid storm, but the most common cause is inadequate patient preparation. If you don't make the patient euthyroid before operating, then there can be a thyroid storm. A 39-year-old lady comes with features of heat intolerance, weight loss. So there are hyperthyroid features. There is a 2 into 2 centimeter thyroid swelling and TSH is low. What is the next step? So I told you the approach. I have told you the approach. Low TSH, hyperthyroid features. What will we do first? Correct. We are going to do a thyroid scan. We won't do an FNAC. We'll do a thyroid scan in these patients. A patient with thyrotoxicosis is being prepared for surgery. Which of the following statements is not true? Beta blockers administered preoperatively should be continued for 7 days postoperatively as well. This I told you is true because the half-life of circulating hormone is 7 days. Iodine may be given preoperatively with carbimazole. This is true. Last dose of carbimazole should be given 1 day before surgery. This is false. It should be given evening before the surgery. It should be given evening before surgery. And nadolol is given as an OD regime. This is true. A 25-year-old male comes with diffuse thyroid swelling. Biopsy shows intense lymphocytic infiltration with Hürthl cells. TSH is increased. So lymphocytic thyroiditis, which one is lymphocytic thyroiditis? Hashimoto's thyroiditis. A few days following viral fever. So they've already given the answer here only. I told you sentinel event is upper respiratory tract viral infection in which condition? A 50-year-old lady comes with painful neck swelling. So another keyword. Viral infection, painful neck swelling, firm enlargement of both the lobes. On investigation, antibodies were normal, T4 was high normal. So this we are dealing with granulomatous or D. quervans or viral thyroiditis. So these were some questions regarding this module, and that brings us to the end of thyroid as a chapter, which is very, very important for all possible exams. Thank you.